Well, let me welcome all of you to our third in a series of virtual roundtable discussions on responding to the COVID-19 crisis. Today's roundtable is going to focus on the key impacts and the needed resources for the disability community that, as we all know, has been deeply affected by this catastrophe. We continue to be very encouraged by the enthusiasm that we have received from our members and our supporters. All of you who signed up today cover the broad range of social insurance policy areas, and your support for these conversations about the importance of our social insurance infrastructure during times of crisis such as this. Your support really makes a difference. In fact, we've heard from many Academy members, supporters, and funders, and I'm hoping you've heard the same thing, that now more than ever, the vital role of social insurance in providing economic and health security to all people really needs to be reinforced. When I look at the unfolding landscape of pain and suffering, I always ask myself, how much worse would this be for individuals, families, and especially people with disabilities if we didn't have support from programs like Social Security, SSI, unemployment insurance, Medicare, Medicaid, family and medical leave, and workers' compensation. This pandemic really is shining a much needed spotlight on some critical gaps in social insurance. We must be honest with ourselves that we have much to celebrate in terms of what social insurance does, but we have to also look at what it could do to further address the economic and health issues that our country faces. So keep your expertise and insights coming. They're invaluable to let us do this work. We need your thoughts and suggestions, and we always welcome your questions. We have 60 minutes allotted today. We might not be able to discuss all facets of the issues that we'd like to cover, but we're gonna make the most of the time. And our next roundtable has been scheduled for May 19th. So we're pretty much on it every other Tuesday timetable, starting at 2 p.m. Eastern time. On May 19th, we'll be focusing on the retirement security prospects for different cohorts of Americans as a result of the pandemic's impact. Now, there's some tools that we'd like to draw your attention to so you can get the most out of today's session. We were hoping to be able to have a closed caption active today. Unfortunately, we're not able to do that. But for hearing impaired members and supporters, we'll close caption the recording of today's meeting, and this will be available on our website later this week. And we welcome your suggestions for making future virtual meetings fully accessible. So there are two ways for you to participate. You can go to the chat box or the Q&A box and type comments for specific questions for the speakers or for other participants to consider. Both are available on the menu at the bottom of your screen. We also welcome questions to be submitted to the Academy via email after you watch the closed caption recording of the roundtable, for those of you who will be accessing the closed caption recording. The chat feature will enable you to have a conversation among everyone. So if you want everyone to participate, make sure that you mark all panelists and attendees as recipients. Otherwise, it'll just be going to the panelists. And for Q&A to the panelists, use the Q&A box. When the webinar ends, we hope to continue the discussion on our website. We have a robust and rapidly expanding COVID-19 section that contains relevant work by Academy members and staff of the Academy. And we always encourage you to share your work with us or bring to our attention other notable work that is addressing the COVID-19 catastrophe. I'm really thrilled to introduce our moderator, Rebecca Vallis. Rebecca is a senior fellow at the Center for American Progress. She's also a member of our board of directors, and as of last Friday, the secretary of the board. And she'll be introducing our panelists, which include two new members of the Academy's board of directors. So Rebecca, let me turn it over to you.
Thanks so much, Bill. And just a huge thank you to the Academy for pulling together this incredibly important series of online events. Hugely timely and really, really important that we continue to center social insurance in this conversation as we think not just about what is, but what could be, as you said, Bill. So my name is Rebecca Vallis. I'm a senior fellow at the Center for American Progress. I am also, as Bill said, the very proud incoming secretary of the National Academy of Social Insurance, and it's my great privilege to get to sit in the moderator seat today for this roundtable. I do want to encourage folks to ask questions, so please take advantage of those tools that Bill was just mentioning, the Q&A box, the chat box. Send your questions our way, and I'm going to do my best to get through them after we get through the presentation and sort of Q&A portion of the panel, and then move to some online Q&A. So get those questions ready, be ready. So as COVID-19 continues to trigger unprecedented economic turmoil, the pandemic has laid bare myriad public policy failures that long predate the spread of the virus, from a broken healthcare system to a woefully outdated unemployment insurance system that has jobless workers running ragged trying to access benefits right now, to an economy where nearly half of U.S. residents were struggling to afford basics like food and housing and healthcare, even prior to COVID-19. One of the groups who was already seeing outsized effects in this moment because of not only heightened medical vulnerability, but also disproportionate levels of economic vulnerability is the 1 in 4 Americans with disabilities and their families, the subject of today's conversation. And worth noting, people with disabilities were facing poverty rates 2 to 3 times higher than non-disabled people prior to the coronavirus pandemic. Meanwhile, our public policy choices in many cases are a big part of why. For example, just one example, because of outdated program rules, many people with disabilities faced asset limits that prohibited them outright from having even modest rainy day savings to weather an unexpected crisis. And now, of course, it's raining. On the flip side of the coin, and another critical part of today's conversation, is our direct care workforce, a group of workers who have always been essential, particularly in the lives of people with disabilities, and perhaps never more so than now, yet who in many cases lack the protective equipment that they need to keep them safe on the front lines of the crisis, and much more as well. Yet both groups are at risk of being largely left behind in policymakers' response, and that's what makes today's panel so incredibly timely. We have a fabulous panel lined up to take a look at how COVID is impacting people with disabilities and the direct care workforce, the policies we need to help both groups weather the pandemic, and importantly, the lessons we should take away in this moment as we think about what rebuilding looks like, what it could look like on the other side. So it's my great honor to introduce our panelists, who I'm going to ask to come on screen now. Meryl Friedman is the Senior Director of Disability Policy Engagement at Anthem, and also an incoming member of the Academy Board. Bethany Lilly is the Director of Income Policy at the ARC of the United States, and Robert Espinosa is the Vice President of Policy at PHI. So one more reminder to send those questions our way using the comment box and the Q&A in the chat box, and also going to invite my panelists to come on screen and share their cameras now.
So Rebecca, we are not ignoring you. We just have to wait for the invite from the host.
I was going to say, usually when you're in the moderator seat, you have all the power. I have no power right now, apparently.
I know. I'm so sorry.
Reminds me of law school, right? I guess it's apparent authority is what I have in spades right now, but no actual authority. So while people are coming on screen, great. Thank you for bearing with us, everyone, for your 19th Zoom meeting of the day, and it's only 2 o'clock. Okay, so just to get right into it as cameras are coming up. So Meryl, I'm actually going to start with you. And I think it's really important for folks as we enter this conversation to have a little bit of an overview of where things stand. How are people with disabilities and chronic health impairments being impacted so far? How are they likely to be impacted down the road by this pandemic health-wise? And what is COVID revealing about the current U.S. healthcare system and how well it does or doesn't serve people with disabilities and chronic illnesses?
Rebecca, thanks for the question. Thanks to the Academy for echo Rebecca's sentiments, for getting us together and having this discussion. And I hope we just planned an hour for that one question, right? I think it's really, and you teed up some of this in your opening comments, but, today we have 60 million people with disabilities, and that number is going to grow exponentially as a result of the COVID-19 pandemic. People with disabilities are definitely disproportionately impacted by all disasters and emergencies, this one included. So it's going to take all of us collectively to work together with people with disabilities during times like this to elevate those experiences and those risks, right? Today I was reading a report, we've seen so many of them where, people with disabilities have been forced to move into nursing homes or other institutions in the past few weeks simply because their needed in-home personal assistance services have ceased due to shelter-in-place orders, fear, stigma, lack of PPE. And so I think as we look at the continued sort of spread of COVID-19, in-home personal assistance may not even have been able to provide the needed services in an individual's home. These are conversations that existed before the COVID-19 pandemic, and they are absolutely exacerbated now. As I have said, not so tactfully over time, all the warts in the healthcare system are showing at this particular point. And that's the greater healthcare system. That is housing, employment, transportation, the workforce shortages that you brought up. So in this particular situation, people with disabilities are also going to likely have to shelter in place longer, have to maintain physical distancing longer than most other people, but still need the supports within their homes. So if people have traditionally gone to a job, both the person with the disability and the job coach are now out of employment. But the needs have not changed. If a personal attendant or a direct support professional cannot get to the person and deliver those services because they don't have PPE, or they're not able to be there, or somebody in their house has been, exposed, or they're showing signs and symptoms, the needs have not changed of people with disabilities at these times. And there are increased risks of people not being able to transfer, an increased risk of pressure sores, no access to food, other daily living skills, bathing, toileting, very critical services that people are providing and needing to access. People with mental health disabilities are experiencing exacerbation, and some people are navigating mental health experiences for the first time. I don't think we have any idea at this particular point how long people will be seeking mental health services, when they will start to seek mental health services. If you look at the work that MHA and NAMI have done, their assessments and research, the numbers are going up every day of people experiencing anxiety, depression, thoughts of suicide. The mental health needs of people who thought they'd never need to access care or medication for a mental health condition are doing so now, are starting to face that reality. People aren't working, that brings extra stress. People with disabilities, people who support them, the families, the family structure. And so we'll most likely, and I say about people with disabilities, I very much fear that they will be the last to be transitioned back to work, both due to the risk of an infection and bias. I think other things that are experienced in the disability community today is just a lack of access to the information, interpreters, low literacy, plain language, so there are other access issues and understanding where and how to access their healthcare or other services, whether there are interpreters at live briefings or things are available to people in accessible formats. So I think, we're going to continue to navigate these downstream effects of the pandemic for people with disabilities. We talk about elevated risk of infection, and that's, I think, that's due in part to support services. When you get, direct support, you have people coming in out of your home, providing the most intimate of services. DSPs, direct support professionals, personal care attendants need to be considered as essential health workers because they are. No good comes at this point, for some extent, ever going to congregate settings and institutions. Our direct care workers are essential. They are saving lives. We should be supporting them to protect themselves and their families as well. Other risks for people with disabilities are more, use of public transportation, underlying conditions we do hear a lot, congregate settings we've touched on. And we can't leave out poverty and socioeconomic factors. You brought that up, Rebecca, as you were, teeing this up as well. So that exists today. So I think, those are a couple of things. I can keep going, but I should probably take a break and let some other people tune in. If you want, I can hit the technology piece pretty quickly before we transition. Is that good?
That'd be great, and then we'll go on from there. But lots more time for folks to be asking you follow-up questions about all of these things, just as we plant seeds about the chat box.
Don't forget, Rebecca's going to tell us that quite a few times for this. Don't forget your questions. So, I think the telehealth piece is really important. I think we made about 5 years of changes in telehealth in 3 weeks. And I think we're experiencing some of the good and the challenges of that. And so I think we're going to have a lot more to come on that. But we really need to look at telehealth as an augmenting of, an access issue. It is good. It provides a safe way to access your healthcare now, to connect with the healthcare support system. But the reality is it doesn't work for everybody. Not everybody has broadband. It's not accessible for everybody. A lot of people are very frightened of it and don't understand who is speaking to them, which, gets in the way of the relationship with your providers. So we can talk about that further too. But I do think that's going to be a road we're all going to be traveling down together with a lot of guidance that is continuing to be loosened up at this point, but it's going to be hard to roll some of it back, but we will. And not everything translates to telephonic or digital. So enough there. We'll come back to it later.
Yep, definitely. A lot more there. And I also do want to come back to hear a little bit about what Anthem has been doing with a lot of your partners in this moment, because there's a lot that can be done that actually doesn't require policy change. And that's important to talk about too.
Exactly. We can
so
come back to
and we will come back to all of it. So Bethany, I'm gonna turn to you next and bring you in. A lot of what you do at the ARC is you lead income security, right? So the health side is hugely important right now, deserves to be front and center in a lot of ways, but we also can't neglect the economic side of all of this. I mentioned up top the toll of COVID-19 is coming on top of existing disproportionate economic vulnerability for people with disabilities and chronic illnesses. So talk a little bit about what the picture looks like on the economic front. What has the policy response been so far? We've been hearing a lot about COVID relief packages. Is it enough to ensure that people with disabilities can weather the pandemic financially? I know a big part of what you've actually been looking at specifically is the $1,200 direct payments that have gotten a lot of attention. How well are policies like that serving and reaching people with disabilities?
I think, unfortunately, it's been, and I think I'm picking up on themes that both you and Meryl already touched on around the warts of the system, so to speak, being really laid bare right now. Because so with the economic impact payments, Congress authorized them as tax rebates, which has some benefits in that they're disregarded from SSI and other means tested programs. So they don't count towards income and they don't count towards asset limits. But unfortunately, they're not using the Social Security system. Like the entire structure of these economic impact payments didn't build on the existing social insurance programs that we rely on. So we're getting monthly checks out to millions of Americans via Social Security and SSI. You would really think that Congress would take a look at that and say, we need to get money out quickly. This is how we should do it. But unfortunately, that isn't how Congress chose to approach this. And so we ended up with these payments not initially being planned to be made automatically to people on SSI, who are people with disabilities who are some of the lowest income people in the entire country. This money is going to go right out the door. It's going to help stimulate the economy because folks already don't have enough money. They've been diving into the very limited savings that they do. And so the fact that this wasn't how it was originally structured is extremely frustrating to me and to my organization, and I think a lot of people with disabilities. Luckily, after a lot of work from advocates, including yourself and many of the rest of us, we have managed to work out ways that the IRS and the SSA are going to issue automatic payments, these automatic impact payments to most Americans on SSI or on SSDI or other Social Security programs. That includes folks who might not be initial filers. So if you want to switch to the next slide, I don't know who has control over that. There we go. So just to kind of give you a big picture of how structuring this as a tax rebate created some problems, looking at the different populations that the people I serve at the ARC and other folks serve, we're talking about millions of workers, but millions of workers who are non-filers and who are also filers. And the filers automatically get their payments, and that's great, but other populations don't. So we had to sort out Social Security recipients, the ones that don't file taxes. Then we had to sort out SSI. One piece that hasn't been sorted out right now is the $500 dependent credit for children receiving SSI. You would really think that low-income kids might be one of the top priorities to make sure we're getting cash out to. But unfortunately, I don't think they've figured out how to automatically pay these children the money that Congress is trying to get out the door as fast as possible. Other populations that we aren't really capturing would be a Medicaid expansion population. So folks who might not be eligible for Medicaid through traditional disability pathways. But Meryl talked a lot about people with serious mental illness and with other types of mental health disabilities. That's about a third of the Medicaid expansion population. And those folks aren't going to necessarily have SSI or SSDI, and so they might not be getting their payments automatically. They may have to fill out a form. The IRS has put out a non-filer form, which I think is very helpful, but people have to know how to file it. And to touch on kind of accessibility issues, it won't work on mobile phones because it has a lot of pop-up ads, which also creates problems for Section 508 compliance. And so it won't work for screen readers. And so a lot of these kind of implicit disability biases are kind of playing out throughout each of these programs. If you want to flip back to the prior slide, I'll just touch on there are a couple of other economic security issues that I think are worth highlighting, especially for the Academy and all of the folks who generously invited us to be here today. I know we've been doing a deep dive into paid leave, and I know the Academy has been as well. And we're seeing kind of America's first try at paid leave. That was kind of what the Families First Act included. And unfortunately, it didn't do the best job of including people with disabilities. So it included many caregivers to the paid sick days piece, but the paid leave piece is limited to parental caregivers. So if you rely on, say, your cousin or your sibling for care, that person won't have access to paid leave. And we're already in, I think, week 8 of DC's stay-at-home order. And so, I love your cat, Rebecca, sorry. And then the other piece of this, I think, would be the unemployment insurance piece. And that's been a question I've been getting because, as Meryl said, a lot of our network, these folks are working. They have part-time jobs that mean a lot to them. I actually have a young man who's been contacting me who works at a grocery store, and he's an essential frontline worker, and he's really glad he's doing that. And he's really glad that his disability doesn't come with a pre-existing condition that means that he's more likely to be susceptible to complications from COVID. But he's like, but if I have to take paid leave, do I have it? And unfortunately, he doesn't because his employer is over 500. And so there are other gaps in the paid leave provisions, but he would be eligible for unemployment under the new programs, which is great. But again, they don't disregard the income from unemployment for a lot of the means tested programs, which means if you get SNAP benefits or you get SSI, there are some serious complications that come along with claiming unemployment. And that doesn't mean that folks can't claim unemployment. It just means that really we should be thinking about how all these systems work. And that was a very broad answer, but.
No, it starts to get into some of it gets very complicated, right? This stuff is wonky, but the devil really is in the details in a lot of ways, and how we design these relief packages matters, right? In terms of who ends up getting reached, and I think that's the larger point you're making. Also, I think it was going to happen. We were going to have cats in the frame if you were going to let me moderate. So sorry, Academy, but you knew better. So Robert, going to you next. We've been talking thus far about people with disabilities and chronic health impairments, but the other side of the coin here is really, really critical too, and Meryl actually already started to broach some of this, and that's the direct care workforce, which plays a huge role in institutional care, but also which is incredibly important to enable people to live independently and in their communities through home and community-based care services. So we'll talk a little bit about the picture right now for the direct care workforce, and what are some of the issues that they're facing and unmet needs that they're seeing right now.
Yes, thank you, Rebecca, and thank you, Meryl and Bethany. If I can just share a little bit of context about the direct care workforce before I dive into some of those barriers. For those of you on the call who don't know about direct care workers, by definition, direct care workers are home care workers and nursing assistants who support older adults and people with disabilities in a variety of settings. They work in private homes, in nursing homes, and in the wide array of residential care settings. We estimate there are about 4.5 million direct care workers in the country, and because of high turnover and growing demand, the number of direct care job openings between 2018 and 2028 will be about 8.2 million. So this is a significant workforce and a significant source of support for people with disabilities and older adults. If we can transition to the next slide. Direct care workers are primarily women, and about 59% are people of color. 1 in 4 direct care workers is an immigrant. In total, there are about 1 million immigrants working in the sector. And the median age for this workforce is about 41, though our research does show that about 1 in 4 workers is aged 55 and older. So we're also talking about a workforce that is increasingly becoming older. If we can transition to the next slide. And the slide after that. Great. Some of the barriers, and Meryl and Bethany and Rebecca, you all have spoken to some of these points, but I just want to emphasize them a bit more. One is that even though direct care workers have been designated by most, if not all states, as essential workers, they unfortunately are not as valued or are still undervalued, both in the sector and in the national response and conversation. One thing I've noticed is that in the variety of telethons and public conversations that you see about essential workers and thanking essential workers in general, you see doctors, you see nurses, you see grocery store workers, even police officers I saw in a recent telethon. But you don't see a lot of home care workers and nursing assistants. And that's shocking given the at-risk populations that they're supporting: older people, people with serious medical conditions, people with disabilities. So they're still undervalued. And one of the ways in which we're seeing this structurally is that a number of workers and their employers are reporting limited access to personal protective equipment, to supplies, and to general resources. We assume that as we see further stages of the response, where we start seeing testing and treatments and vaccines, that if these workers are not prioritized and their settings are not prioritized, that they may also not be first in line to receive that. And that's only going to put older adults, people with disabilities, and people with serious medical conditions further at risk. Direct care workers, the median wage for direct care workers is around $12 an hour, and about 42% live in or near poverty. So they come into the coronavirus with already inadequate compensation and benefits. But what this means in this moment is that workers are forced to make the impossible choice of going to work, not being sure that they'll have the protective equipment, and then risking getting infected and their families and their clients infected, or staying home and collapsing financially if they don't have access to paid leave, which many workers don't. So unfortunately, this is leading to, if we can transition to the next slide, a growing workforce shortage in this sector. The sector for a long time has been dealing with workforce shortages. Employers have long reported challenges with recruiting and retaining workers. And we're seeing that in this moment, because workers are becoming sick, or they're choosing, maybe not to go to work because they don't want to get themselves or their family sick, that employers are and consumers are increasingly reporting challenges with finding workers, and this leaves many people stranded without support, and it can create a real crisis situation. We've often pointed out that many states have limited data collection systems where they're able to report how many workers are in any given area of the state. And as we see certain cities or certain counties become hotspots, what is the likelihood that the state will be able to understand the extent to which there are available workers, right? The lack of available data, the lack of testing to be able to track infection rates, et cetera, is going to make it difficult for states to know where they can kind of move workers and where they will see a shortage coming. And then finally, we're seeing a tension and trying to figure out how do we train more workers as direct care workers, specifically as home care workers. One, to build a pipeline that's needed right now. Maybe potentially reaching out to newly displaced workers and figuring out what that method looks like. And then also training workers on COVID-19 and on in general infection control practices across all settings. One of the challenges is that for years, this sector has really relied on in-person methods. And so to be able to transition from that type of modality to one that's online has a cost attached to it. And I think we're seeing in research that's coming out that that's an expensive cost that many providers aren't able to meet. So I'll talk a little bit about solutions and what state and federal governments can do in that regard, in regard to all of these barriers in a second. Thank you.
Great, wonderful. No, that's a perfect place to leave it for now. Meryl, I'm going to come back to you on the health side for a minute to pick up kind of one of the threads that you were weaving before. I guess if I'm going to keep the weaving metaphor going, I have to do it. You at Anthem have been working with national community partners to support people as well as providers, people with disabilities as well as providers in a whole bunch of different ways. You've also been working with a broad coalition and partners and trades to really kind of align around a set of critical policy changes to better support people with disabilities, both in this moment and also on the other side of the pandemic, whenever that is. I would love to hear you talk a little bit about the policy response that we need to see both in this moment and longer term, so that we don't see the kinds of massive gaps that folks like you and others are now stepping into the breach to try to bridge.
So, a couple of things, and I always just start here because I think, it's so critical when we talk about anything relating to people with disabilities is we need to include people with disabilities in the discussion. They should be included in every aspect from disaster preparedness and response to policy discussions, right? Because it's all interrelated, but this should all happen with people with disabilities, with community leaders, with advocates. And then we should partner with them. And I think that leaves, it closes a lot of gaps by people not making decisions for other people, particularly for people with disabilities throughout this process. And, we always say about those of us with disabilities and different types of disabilities is that if you want, the most resourceful people in the world are going to be people with disabilities. So if you want to get from point A to point B in any challenging situation, include people with disabilities. And other than that, it is just simply the right thing to do and the only way to approach moving forward. And to maintain that open dialogue. It's not a one and done, right? This is an ongoing conversation. Things are changing every day, every week, and they often do. But we've also learned very much that aligning with many of the trade associations and elevating the voice and elevating the collective voice, right? And elevating the experience and the connections to do so with these trades. So working with AHIP, working with the National MLTSS Association, working with Advancing States, which is the organization that the Aging and Disability Directors are part of, and it's just like NAMD, the National Association of Medicaid Directors, where the Medicaid directors are part of that. And it takes all of us to be aligning messages and moving these priorities forward. And it takes the National Rural Health Association. It takes ANCOR, right? Everybody, and then all of the organizations that we work in and with, to be able to combine these messages and move them to different people, use the relationships and the platforms that we have. So I think that's really been pretty critical. That's what we're doing. And lots of familiar people on this call are doing the same thing. If we go to the next slide, we'll talk about a couple of key points, please, since I can't recall much off the top of my head. There we go. Thank you. So we even worked with our National Advisory Board, Anthem's National Advisory Board, which is convened by Lex Frieden, one of the architects of the ADA. to get some of these points out to the Congress as well. Of course, talking about supporting personal care attendants and direct support professionals, other home care workers who are supporting people with disabilities themselves and their families, those older adults, creating equal access to healthcare and treatment services. I mean, goodness gracious, healthcare rationing. I know of situations where people have gone to the hospital, people with disabilities with their own ventilators, and hospitals have tried to take them away and give them to other people. This is just not cool. This is not 2020. And although 2020 has been odd so far, that is a really bad practice that every single one of us needs to step up, to put a voice out for. Providing exceptions to restrictive hospital visitor policies to make sure that people with disabilities have people with them at all times for in-person support, both from an understanding of what is going on and a safety measure as well, including coverage of peer supports. And we talk about peer supports, we always talk about peer supports for supporting people with mental health and substance use disorders, but there are peer supports for people with physical disabilities, peer supports for people with intellectual and developmental disabilities, brain injuries. So I think we really need to elevate that as well through this process and get those services covered. It takes everybody right now to help the next person next to them because everybody's reaching out in a different way and in need. So I think we need to really be aligning on 42 CFR as well when we talk about peer supports for people with mental health conditions and really looking at these 90-day supplies of medications so people can actually have what they need because we don't know what comes next with this pandemic right now. On the guidance around sheltering in place, we hope we're looking at maybe a loosening of that and a coming out, but we don't know. And so that was really important. But we had to address some of those barriers right up front because there was the Controlled Substance Use Act that got in the way of people with seizure disorders trying to get the medication. And so like Lyrica, right? And so every time you dig into this, you find something else that you have to address. And that's why it takes all of us because it is very rapid, very fast, and a lot of detail. You said the devil's in the details, and it really is.
Amen. And I want to, hearing you talk, I want to be really clear also just for anyone listening who's not familiar with the healthcare rationing piece of this conversation. I would agree with you. It is so not 2020 to talk about that in any context, but especially in the context of disability discrimination. It's also not just not 2020. It's in flagrant violation of the Americans with Disabilities Act and Section 504 of the Rehabilitation Act. And we could list them. So we could have a whole roundtable on that. I'm not going to divert it there, but just wanted to note that clearly for anyone wondering as they're hearing about the concept of healthcare rationing in this moment.
Exactly, and hit the OCR, right? OCR stepped in, the Office of Civil Rights, get on their website. There's good information out there.
Yep. Not a question mark. So OCR, I should also say, is the Office of Civil Rights. And Bethany, so bringing you back in, you started to talk about paid leave. You started to talk a little bit about unemployment insurance and some of the ways that, again, the devil ends up being in the details for how you design these packages and the ways that people with disabilities, as well as many other groups, are being left behind in some of these emergency relief packages. But there's a whole agenda that you and other disability leaders have really been trying to bring to the forefront, and paid leave is part of that, and unemployment insurance is part of that. Talk a little bit about the policy response that we still need to see so that people with disabilities can actually be reached and instead of being left behind the way that they largely have been to date.
And I think Meryl had a really good list, to be honest. I noticed a lot of things that the disability community has been prioritizing as well. I mean, making sure that DSPs and PCAs and other direct care workers have access to PPE and are essential, as Robert talked about earlier, is hugely important. Making sure that Medicaid home and community-based service providers have the resources they need to stay open. I mean, we're talking about completely transformed systems right now where people can't access their usual services because they're usually person-to-person services. And so this has been a really strange time for the disability service system and a really hard time. And we're hoping that the next package will actually include not only the protective equipment that Meryl talked about, but also make specific funding for HCBS services to keep people out of institutions. And I think that's one of those things that I just before getting on this webinar, I saw a news article that said 1,700 people had not been reported as dead in New York. because they died in nursing homes or other institutional facilities. And this is something that I don't think is breaking through the news, that we, like, millions of people with disabilities, millions of us are dying in it, well, not millions, but hundreds are dying in institutions because they don't have the community services that keep them from being in these congregate settings where the virus will spread so quickly. And so I think I just a little worked up about that, but I think that's something that we need to, like, kind of always center the movement around, is that, you know, there are still institutions in almost every state, and that's something that we don't talk about enough, and our folks are dying there, and that's incredibly frustrating. But that also leads but that also leads, I think, directly into kind of some of the other pieces, you know, like, one way that you can get around that if your direct support professional has come down with COVID or your day program is closed, is your parents or your family or your friends can step up and provide the supports that you need. And in an ideal system, we would have a social insurance safety net that can kind of pick that up and say, okay, you need to take time off to be with your family or to help take care of your family members. Let's make sure that the paid leave system we have kind of covers that. And a lot of states over the past several years have done a great job of kind of expanding paid leave to make sure that it covers a lot of people and that folks can take that time off to be with their families. What Congress did has, as you said, the devil's in the details, a lot of gaps. And the emergency paid sick days are great. They're 2 weeks. They're broadly available for coronavirus related reasons. So if you are a person with a disability and you need to self-isolate, this would cover that. If you need help from your family member to self-isolate, that family member can take time off. If you need help because your usual source of care is gone, your family member can take time off. Like, it's a good program, but it's only 2 weeks. And since we're in week 8 of the stay-at-home order, at least here in DC, I think, you know, we're already seeing how that falls apart. One thing that's not on this slide, but that I think has been getting a lot broader press coverage, is that these provisions don't apply to employers with more than 500 employees. So by and large, those folks aren't going to be covered. In addition, healthcare workers are exempt, which is a little bit well, it seems a little contradictory to me, because wouldn't healthcare workers be the people we would want taking time off if they happen to get COVID? Because we certainly don't want them exposing the people that they're serving. And so, yes, we're in a healthcare crisis shortage, but we need to be kind of balancing safety for people and exposure and the rest of this. And I think how we structure a paid leave program matters a lot for that. As I said earlier, the emergency paid FMLA leave is limited just to parental caregivers. And that could be if you have a young child. It could be if you have an adult child with a disability that you need to take time off. But unfortunately, again, we're in a situation where folks may in fact be not able to take the time that they need because maybe they're a sibling. Maybe their parents have already passed on, unfortunately, and they've been the primary caregiver for their sibling with a disability. We actually have a lot of folks like that in our network. And so we need to make sure that this is covering a broad group of people so that every family can kind of take what they need. The other piece, and the example that like immediately comes to mind when people talk about the details, is the next slide, which is unemployment insurance. And in no small part because I've been spending a ton of time digging into the weeds on this because it's a really complex issue. So CARES had 3 different pieces of unemployment insurance expansion, which was great because one of them tried to get at expanding this kind of social insurance to gig workers in the new economy and kind of thinking about how the new economy should be wrapped into this. And that's means that a lot more people with disabilities who generally work part-time, generally work low-wage jobs, and generally don't make a lot of money and rely on social benefit programs, like a lot more of them are going to get captured along with the part-time workers and the gig workers. And so that's great. The problem is because they rely on those other forms of social insurance or those other forms of benefit programs, it could really jeopardize healthcare. It could jeopardize access to SSI. It could really have unintended consequences that I really wish Congress would maybe think about a little more. They did, obviously, included in CARES, and one of this was disregarding kind of the enhanced benefit levels for the unemployment insurance. And I included the citation because I just think Congress clearly was thinking about this. And that's great, but a lot of people with disabilities access Medicaid via the SSI eligibility pathway. In almost the vast majority of states, it's an automatic Medicaid eligibility pathway. And the $600 a week benefit that they're boosting with the unemployment insurance, that's going to put most people over income for SSI, which means suddenly they won't be eligible for Medicaid, not because their Medicaid eligibility changed, but because their SSI eligibility changed. And so this kind of unintended consequence led the Centers for Medicare and Medicaid Services to put out something specifically addressing this issue. And in large part, the only reason this isn't a problem is that Congress included a maintenance of effort requirement when they passed the second law. And so Congress fixed the problem that they kind of created and that they didn't really think about. And so this is just kind of my perfect encapsulation of how the system really they need to think about how the different systems work together when they're building these new social insurance models or when they're kind of boosting existing ones now.
It's sort of unfair to force you guys to talk about all these things without the benefit of a glass of wine. So something for the Academy to think about in terms of the scheduling and the time of day that these happen moving forward. So Robert, you're going to get the last question before we move over to audience Q&A. So get those questions ready, send them in. We're about to turn to them in just a couple of minutes. But Robert, you started to mention, and also I should mention, you are also an incoming member of the Academy board. I should have mentioned that before. So 2 incoming Academy board members on this panel. So you mentioned before, as you were starting to walk through your the barriers and the problems that the direct care workforce is facing in this moment, you started to mention, and this is where I would love to have you sort of take us home before we go to audience Q&A. What is it that you hope to see from leaders right now at all levels of government to make sure that we're supporting this critical workforce? What has the response been so far, and what's missing?
Yeah, thank you, Rebecca. And I will cover these points quickly so that we can move to a Q&A. So there are a number of measures that state policy leaders, state governments and federal governments can implement to support this workforce in this critical moment and hopefully beyond. A major piece is that I think we need to improve compensation for workers, and we've seen a few states increase it temporarily for direct care workers, but it needs to happen across the board, and really it should happen long term. It is one of the primary reasons that direct care workers leave these jobs, and it just doesn't match the level of skill and the value that these workers provide to older people and to people with disabilities across the spectrum. We are seeing, especially in a coronavirus moment, because schools are closing, that many workers need access to affordable childcare. And we saw in New York, and probably in a few other states, measures that improved access to free childcare or low-cost childcare. And I think we need to make sure that we continue to provide that free or low-cost childcare to essential workers like direct care workers. We absolutely need to ensure access to personal protective equipment, to the variety of supplies and down the line, to testing, to treatments, to vaccines, et cetera. One of the things we're seeing is that increasingly smaller agencies are launching their own fundraisers, their own crowdfunding fundraisers to purchase supplies, which of course raises questions about how much we failed as a system when people are forced to fundraise for themselves kind of outside of the system to get the same supplies that they should be getting. And so really states should step in and make that more standardized and high quality. If we can transition to the next slide. A few other pieces is that, as Bethany mentioned, the paid sick leave policies that have been implemented have left a number of gaps. And so we think that states can step in and offer those emergency paid sick leave policies, at least to healthcare workers and direct care workers in particular. We need to figure out how to disseminate high quality training, probably virtual training on COVID-19 to all direct care workers. And states need to create new pipelines into direct care jobs, maybe taking advantage of capitalizing on a moment in which there are a number of newly displaced workers who are looking for jobs and might be able to play that role. And how do we expand access to healthcare? 1 in 10 direct care workers does not have access to healthcare coverage, and we need to make sure how do we expand that And how do we include free COVID-19 testing and treatment for all workers so they can be as safe as possible on the job? If you can move to the next slide. At the federal level, in mid-May, Senator Casey introduced the Coronavirus Relief for Seniors and People with Disabilities Act, which included a number of measures that would have really strengthened the direct care workforce if they would have been implemented in any of the relief bills. It specifically would have provided funding to state Medicaid programs to improve compensation directly into direct care workers' pockets. It would have included also funding to cover paid sick leave, paid family and medical leave, hazard pay, overtime pay, shift differential pay. Would have helped with expanding home and community-based services to individuals on wait lists, and so on and so on. Unfortunately, it hasn't gained traction in any future relief bills. We think one of the challenges is that it is attached to a Medicaid provision, and Medicaid remains a very charged kind of partisan policy issue, and it's making it difficult to fund, but it is something that needs to be included in federal approaches. There are a number of workers, specifically who work for home care agencies that are smaller businesses that may not have access to paid sick leave, and nursing assistants also, because maybe they're considered healthcare workers under these paid sick leave measures, are not included either. And so how do we fill those gaps? We need to implement at the federal level and provide funding for states to implement immediate recruitment campaigns to bring new workers into this sector. If I can transition to the next slide. And then just a few more, federal funding that allows states to explore online training, both to bring new workers into the system, but also to be more versed in COVID-19 care, competency evaluations that can quickly assess and screen new workers. Maybe they already have these skills and can quickly enter these roles. How do we increase funding to providers and to consumers to enhance training infrastructure, especially if they're moving to virtual methods, which require a specific skill set and might be, a certain cost as well. How do we tap into the knowledge and the experience of workers themselves and work closely with worker organizations to understand what workers are dealing with, what is specifically they want, and how do we improve data across the long-term services and supports system about COVID-19 infections and deaths? Where are these infections and deaths happening? How are workers affected, et cetera? And one small editorial point that I'll leave you with before I move to a Q&A is that one challenge with direct support professionals in particular when it comes to data is that there's no federal occupation code on direct support professionals, which makes it difficult to accurately get a sense of how many direct support professionals there are at the federal level and at the state and local level. And so this is an opportunity for us to rethink how we're measuring that part of the workforce, which of course is incredibly valuable to people with intellectual and developmental disabilities. With that, I'll leave it open.
There's a ton here, and so many more directions we could go with this. So I'm going to turn there with tremendous thanks to our panelists and to the folks who have been throwing questions into the Q&A box and to the chat box. We have some fantastic questions. I'm also going to go ahead and say before we get into them that a lot of these are ones that I think people would probably really love to have follow-up on. So if we can't get to all these questions, and we probably won't be able to, I'm very happy to work with the Academy and with these panelists to get follow-up answers to folks who are asking these questions. A lot of really good stuff in here. So multiple questions on the dangers of institutions and of people dying in institutions. And in fact, one question, I'm going to read parts of it because of how it ties some things together here. One of the most urgent policy issues right now is inclusive public health reporting. Real-time tracking of COVID-19 morbidity and mortality among people with disabilities and chronic conditions, including in institutions, will be essential for developing targeted interventions. It goes on. And the connection to institutions here, there's another question where someone asks for numbers. How many people are dying in institutions? So I can say, and I'm happy to share a link so that people have this resource and then turn it over to our panel to weigh in more. But the estimates that I have seen as of a few days ago are that 10,000 people have now died in institutions, including both people receiving care and their staff. And that's an analysis that comes to us from Kaiser Health, and which they believe is an undercount. Because they believe that not all states have been reporting the data and tracking the data. So with that, would love for each of you, any of you who want to weigh in, to talk a little bit about the institutional care side of this, what COVID is laying bare that existed before now, and what the answer is kind of as we move forward, and how data plays into all of that as well.
So I do know that the Autistic Self-Advocacy Network has instituted a tracker. And I dropped the link into the chat box, so if folks want to follow up. They can also just go to the, if you search autistic advocacy, it'll pop up, and it's right there on the front page. But I think that this is a huge problem, is that we don't have good numbers on this, and we don't have, I mean, part of the challenge that historically we've had here is that we don't have good numbers on how many people live in institutions right now. We don't have good numbers on what kind of capacity would we need to make sure that we can move people out. I mean, I know that people in Congress are thinking about creating or like giving nursing homes flexibility to open COVID wings, because they are just acknowledging that COVID is going to spread really, really quickly through institutional settings. And I think that's just something we have to kind of focus on. I know there are also demographic bills that are currently circulating in Congress, and the Leadership Conference for Civil and Human Rights has been doing a lot of leadership around making sure that demographics are included. And I know they've been listening to the disability community when we've been saying that needs to include people with disabilities, and it needs to be comprehensive and include people in institutional settings, because we can't just forget about these people. I don't know if others want to add to that, but I think you're entirely right that that's a huge gap in our knowledge base right now.
So a couple of links now that have been sent out. Folks should take a look at those. I'm going to keep us moving because I think that was a great answer, and try to hit a couple of other questions as well in the time that we have left. This one actually comes from, I believe, Elaine Perry, who is also a new Academy board member. Since this epidemic is likely to continue in some form for quite a while, it seems likely it will also give rise to a need for a new category of disability accommodations. Right now, many workplaces are allowing people to work at home if at all possible, but once the orders lift and people are called back to work on site, maybe with some protections, what if they're not adequate for people who are high risk? And the rest of the question kind of goes on, should we be thinking about creating some kind of a new set of accommodations? Does anyone have thoughts on that for Elaine? A really interesting question.
That one kind of takes some opining. If I had, I see Bethany nodding her head. If I have it right, you know, if we create a new category, are we fragmenting the disability community and the strength we have, the solidarity that exists today? And I don't know. I really would I'll think on that one for sure.
Yeah,
All right.
it does raise. Oh, I'm sorry.
Please, Robert.
No, I
please.
agree with Meryl that I think it's probably opining at this point, and I agree that it raises questions about categories. I do think, you know, I fit into that category of people who are at high risk, and I live in New York City. And when I think about the density of this city and the subway train, I don't know what kind of situation we need to exist in the city for me to feel safe. I mean, even going on a subway system. And so I whether it's a category or whether it's a whole new paradigm of protocols and policies and ways of thinking that, you know, provide accommodations for people based on their health profile, their disability status, their preferences. I do think that it will hopefully create good thinking among industries and employers to do that. But what we know in real life is that there's a line between people who work for employers who do that and people who work for employers that do not do that. And those people are often low-wage workers. They're people who are always at risk for a variety of reasons. And so I think we're going to see that inequality emerge even more as we think about who can safely navigate the shutdown and the lifting of the shutdown. Yeah.
Yep, I think that's incredibly well put, and such a great place, I think, to end this, given the tremendous inequality that is the through line for pandemic, and who it's impacting and how, and what you're saying resonates with me as another person who's high risk because of chronic illness and disability who's lucky to be able to work from home and have an employer for whom that's okay, right? That's just not going to be the case for a lot of people. With that, please join me in thanking our incredible panel today. A lot of questions we didn't get to that we will follow up with you on to get folks answers, but Meryl Friedman, Bethany Lilly, Robert Espinosa, thank you so much for taking the time to join us today for this virtual roundtable. And my cat, wherever my cat is, thank you for your little drop-in appearance that was unsolicited. And with that, I'm going to turn it back over to Bill Arnone to close us out.
Well, I have to unmute myself. Am I unmuted? Okay. Thank you to the panelists, not only for your knowledge, but for your passion that really came through today. All of you will receive an email following this virtual roundtable with a link to a brief survey. Please do fill it out. We make changes based on feedback, so please let your thoughts come to us right away. We'll continue to provide opportunities to exchange ideas through virtual forums such as this. As I said earlier, May 19th, if you mark your calendars, is our next roundtable. You'll get more information by email. Also, our website is continually updated with new resources, so please go on that and continue to be appraised of COVID-19 from a social insurance framework. You might have also gotten many emails today because it is Giving Tuesday. Because of contributions we get from our members and others, we're able to have virtual roundtables such as this. So if you can, please consider making a donation to support either our work or the work of the organizations represented by our panelists today. And there are several ways you can do this that we're showing on our slide. For those of you who are members of the Academy, thank you very much for paying your dues. I know I sound like a broken record on this, but dues are our lifeblood. It lets us do things like these virtual roundtables. But more importantly, well, not more importantly, as importantly, are your views, your thoughts, your insights. So please keep them coming to us. And we look forward to another Zoom session in 2 weeks. Most importantly, over the next couple of weeks, please keep safe and healthy and keep in your thoughts those of us who we know not fared too well as a result of this pandemic. Thank you again, everybody. Bye-bye.